Good day, everyone. The Massachusetts Medical Society is pleased to present new opioid prescribing guidelines in practice. Now it is my pleasure to introduce today's speaker, Dr. Daniel Alford. Dr. Daniel Alford is an Associate Professor of Medicine, Assistant Dean of CME, and Director of the Safe and Competent Opioid Prescribing Education Scope of Pain program at Boston University School of Medicine. He is on staff at the Section of General Internal Medicine and Director of the Clinical Addiction Research and Education Unit at Boston Medical Center. He is also Medical Director of the Office-Based Opioid Treatment Program, the Boston University Evidence-Based SBIRT Training Project, and the Massachusetts SBIRT Training and Technical Assistance Program. He is immediate past president of the Association for Medical Education and Research in Substance Abuse. He was recognized as Champion of Change by the White House and in 2014 received the National AMA Award for Health Education. His clinical education and research interests focused on opioid use disorders and safe and competent opioid prescribing for chronic pain. Welcome, Dr. Alford. Let's get started.
Thank you very much. Happy to be here. So I'm going to be starting with putting chronic pain and prescription opioids into perspective. Then I'm going to talk briefly about what is now being considered safe opioid prescribing practice. And then we'll spend half of the time really going through what the Mass Medical Society guidelines say and how we can comply and adhere with those. And so first, let's put chronic pain in perspective. And according to the Institute of Medicine report back in 2011, it's estimated that 100 million individuals in our country suffer with chronic pain. And boy, that's a third of our population, and if you think about it. But really, when you think about where this information came from, it's really based on extrapolation from survey data where they ask people, have you had pain that's lasted more than 3 to 6 months? And in that way, it's not so surprising that such a large proportion of our population would say yes to that. And other surveys have found that up to 25 million have moderate to severe pain, so not just mild pain. But I think one of the principles that they discuss in that report that really resonates with me is how chronic pain really can be a disease in itself. And that is, as we know that acute pain is a symptom that's life-sustaining, as far as I know, there's no benefit to us as organisms to suffer chronic pain. And chronic pain becomes very multidimensional, very much like a lot of the other chronic diseases that we manage every day in clinical care. They also talked about some barriers to adequate pain care, including negative attitudes and disparities in pain care, lack of decision support for chronic pain management, a financial misalignment favoring the use of medications, poor support for team-based care and specialty clinics, and really an overburdened primary care system. And we'll talk more about that. But what you see from data over the last decade and a half is that as a country, starting in 1999, we have been prescribing more opioids, and this is based on kilograms of opioids sold per 10,000. And, frankly, I don't know what the right amount of opioids are, where we should be on this line, but what I will be showing a little later on are some associated trends that are worrisome, for sure. So why is there overprescribing of opioids? And I think it really is a confluence of factors. And clearly there's a lack of training in pain and education, and not just among physicians, but among nurses and behavioral medicine specialists and our colleagues that we work with on a daily basis are also poorly trained in pain and addiction. I think there's also a societal medication mania. That is, folks, when they come to us, expect medication for whatever is ailing them, especially when it comes to pain, and they're really looking for fast relief from whatever is causing them to suffer. And I think patients and families have become overly focused on opioids as a magic bullet or the treatment that everyone should be getting for pain issues. You could also blame the Joint Commission's pain is the fifth vital sign, where we become very focused on assessing pain, although nowhere in their recommendations does it say that we should be prescribing opioids, but I think just asking people about pain and people wanting opioids probably led to this. But clearly, the pharmaceutical industry has over-marketed these medications as safe and effective. But we, I think, also are very eager to relieve pain and suffering among our patients. And And when we decide that opioids aren't indicated or that we need to stop opioids because they're lack of benefit or causing harm, we get into a discussion that's uncomfortable. And so I think there is some confrontation phobia among us that we need to deal with. And then finally, lack of pain specialists offering comprehensive pain management. And so we know that there are some pain specialists out there, but many of them are just doing very specialized care like injections or nerve blocks. And what we really need for these patients with chronic pain is a comprehensive pain program that we really that are not readily available to us or our patients. So this is the slide again that showed the increase in opioid prescribing over the last decade and a half. And what I now included are two lines that show, one, an increase in opioid overdose deaths that are unintentional, as well as an increase in people seeking admission for addiction treatment for opioid use disorders. And although these lines are not showing causation, that one caused the other, I think the associations are hard to ignore since they all kind of go in the same exact slope. So this is really why we're here today and why guidelines were developed by the Society in the first place. But it's not also just about prescribing opioids. It's also related to dose. And we now know that high-dose opioids are more risky. And this was just one population-based study. There were a number of them done around the same time in 2010 that showed that the higher the dose, the increased odds ratio of overdosing. And in this study, if a patient was on greater than 100 milligrams of morphine equivalents, they had a 9-fold increase in overdose. And so I think we now appreciate the risk of patients being on high-dose opioids. We'll talk more about that. But locally in Massachusetts, we know that for a decade, the opioid overdose deaths were pretty much stable. I mean, they were never acceptable, but they weren't moving very much. But lately, over the last few years, we've seen a dramatic increase in the number of unintentional opioid overdose deaths. And this has resulted in the governor convening a task force and proposing legislation to try to stem this overdose epidemic, which I'm sure reading the local paper every day, you'll see that this is a hot topic for our legislators in trying to fix this problem. Now, how good are opioids for treating chronic pain? Well, we also know that it's been inadequately studied, and I would argue that it's absence of evidence rather than evidence of absence. That is, we just don't have great studies out there looking at people over the years and years and years of getting opioids. And so most of the literature are surveys and uncontrolled case series. There are some randomized clinical trials, but they tend to be of short duration, less than 8 months, and with small sample sizes. They're mostly pharmaceutical company sponsored. And what do they find? Well, they find better analgesia with opioids versus placebo. But the pain relief is modest, and it's modest just like everything else that we have to offer our patients with chronic pain. You name it, whatever the medication is, the pain relief will be modest. And really, it turns out that when we combine therapies, we get a much more robust response. But any treatment by itself is modest, but we shouldn't completely discount it. So a patient might go from an 8 to a 6, and that might make all the difference in the world for a given patient. But they shouldn't be expecting to go from a 10 to a 0 on a 10-point scale. So we need to make sure our patients understand that. There are mixed reports on function. Some studies show improvement in function, some don't. And unfortunately, addiction is often not assessed in these studies. Now, what about the problems of opioid use in chronic pain? Well, from a recent systematic review from 38 studies, about a quarter of them are from primary care settings and over half are from pain clinic settings. What did they find? In terms of misuse rates, it's somewhere between 21 and 29%. And the definition of misuse is really opioid use contrary to the directed or prescribed pattern of use, regardless of the presence or absence of harm or adverse effects. So this could be, a patient who you're prescribing opioids for their back pain and they take it for their headache, or you're prescribing it for their neuropathic pain and they're taking it to help relax. These are all misuse of opioids. In terms of addiction, the addiction rates from the systematic review were somewhere between 8 and 12%. And the definition of addiction is a pattern of continued use with experience of or demonstrated potential for harm. And harm is defined as impaired control, compulsive use, continued use despite harm, and craving. And so these are the best rates that we have in terms of when we treat patients with opioids for chronic pain. What is the rate of misuse and the rate of addiction? We also worry about collateral opioid risk. And it turns out that a lot of, from a national survey in drug use and health, when they ask individuals who have used a prescription opioid that was not prescribed to them, where did they get it? 2/3 got it from a family or friend. And either they stole it from a family or friend, bought it from a family or friend, or were given by a family or friend. And so we really need to worry about collateral risk. That is, young children ingesting and overdosing, adolescents and their friends experimenting, leading to overdose and addiction. And so we need to talk to our patients about mitigating risk. That is, safe disposal and storage, including a lockbox. Really educating family members about the risk and the dangers of these medications if they're taken without a prescription. They should have a poison control number handy. And this whole issue around co-prescribing with naloxone we'll talk more about. But there's a very useful website, Prescribe to Prevent, that has lots of information for patients, for physicians, and for pharmacists around naloxone and how to prescribe it. Now, I want to just briefly talk a little bit about kind of safe prescribing and what do we mean and what are the guidelines, the national guidelines telling us. And then we're going to move on to what do the Mass Medical Society guidelines tell us. So this is a primer of safe prescribing. The first thing, which maybe goes without saying, is it's more than about opioids, right? It really starts with self-care. And our patients shouldn't be coming to us anymore saying, you need to fix my chronic pain, because they need to own some of this. They need to really start thinking about how to take care of themselves, how to modify their activities and pace themselves in order to keep healthy and so forth. And that the goals are really not only to reduce pain, but to restore function, to improve quality of life, and to cultivate well-being. And in order to do that, or the way to do that, involves not just medication, but physical therapies, psychobehavioral therapies, and procedural therapies. And, I think the more that we can offer our patients, the better. And it's completely understood that currently a lot of these therapies are not available for our patients, but hopefully in the future they will. But really, medications is just one piece, and opioids is just one piece of that. So we really need to start focusing on these other therapies as well, to the best of our ability. But when are opioids indicated? Well, clearly when pain is severe and has a significant impact on function and quality of life, but also non-opioid treatments have been tried and they've failed. And it's not just non-opioid pharmacotherapies, but also, non-pharmacotherapies have been tried and failed. But finally, really the patient needs to be agreeable to take the opioids exactly as prescribed. They need to appreciate the dangers of, escalating their dose on their own. So really, we need to have zero tolerance for unsanctioned dose escalation, and they need to be agreeable to have their opioid use closely monitored for safety, including pill counts and urine drug testing. And when we start an opioid, we need to realize that it's a test or a trial and that it's going to be modified or discontinued based on ongoing risk-benefit analysis. And always start low and go very, very slow with these medications. Using the risk-benefit framework, we're looking for improvements, again, in pain and function and quality of life, and we're worried about misuse and addiction and overdose and death and adverse effects. And so each time we write a prescription for an opioid, we need to convince ourselves, make a decision that to continue or to modify or discontinue that opioid is based on this risk-benefit clinical assessment that we've made, and we need to document that. How do we assess benefit? Well, there are various tools out there, but I would highly recommend this one, which is called the PEG scale. This PEG scale was derived from the Brief Pain Inventory assessment tool, which is longer. And these are 3 questions which I think address the 3 domains we're interested in. And so P stands for pain, E stands for enjoyment of life, and G stands for general activity. And the questions are asked: what number best describes your pain on average in the past week? 0 is no pain and as bad as you can imagine. 2, what number best describes how during the past week pain has interfered with your enjoyment of life? 0 doesn't interfere, 10 completely interferes, and then how much does it interfere with your general activity? Doesn't interfere, completely interferes at 10. And so all of these questions are asking about the past week, and they're asking about, folks to grade their pain from a 0 to a 10. And it's not going to prove or disprove someone's pain. But what it will allow you to do is to monitor people over time. So, frankly, one person's 8 is someone else's 10 is someone else's 6. So it's hard to compare between patients, but for any given patient, we should see some improvement over time with whatever therapy we're instituting, whether it be opioids or something else. But in order to keep our patients safe, we also need to apply universal precautions, which I think most people are starting to hear about, and although it's not evidence-based, it really is becoming standard of care by lots of different organizations. And we're very familiar with universal precautions as it applies to infectious diseases, that we assume everybody has some degree of risk and we need to protect ourselves when we're handling bodily fluids. Well, we should also assume that people who are prescribed opioids, that we have no way of proving with 100% certainty who has zero risk. And therefore, we should assume that everybody has at least some risk. And so how do we apply universal precautions around pain management? Well, first of all, you're going to use a risk assessment. Like, what is their risk for misusing the opioid? And there are a number of risk assessment tools out there. I'm just listing two here, and I'll show a little bit more detail of the opioid risk tool. But really, we're talking about asking people about a history of substance abuse, a family history of substance abuse, a history of mental illness, a legal history, and so forth. Things that are pretty, they make sense, and they've been determined by observational studies to be risk factors for misusing opioids. We also want to use an agreement, a patient-provider agreement, that really talks about risks and benefits of opioid therapy, but also outlines what the plan of care is, including monitoring, like urine drug testing and pill. We want to have frequent face-to-face visits, and, how you determine frequent depends on how risky it is for any given patient and how comfortable you are in terms of prescribing. But we'll look at what the Mass Medical Society says. And then we want to monitor for adherence, addiction, and diversion by doing the urine drug testing, the pill counts, checking the prescription monitoring program, and there are some other tools like the current opioid misuse measure, which is a 17-item self-administered questionnaire that patients can do in the waiting room, which kind of gives you a measure of risk of misusing opioids when people are already on opioids. So in terms of, the patient-provider agreement, talking about realistic goals, I think, again, it's important to remind our patients that we're trying to reduce their pain, and we may not be able to eliminate it. And the reason why that's important is if the patient has unrealistic expectations or their family has unrealistic expectations, they're going to want more and more medication if they haven't achieved zero pain. So we need to make sure they understand this goal. But even more importantly is how do we even create functional goals, and I think they should be SMART goals. And what do I mean? They should be specific, they should be measurable, action-oriented, realistic, and time-sensitive. So they shouldn't be, I just want to feel better, I want to be able to do more, because those are things that we can't necessarily measure. But I want to go to the store twice a week, or I want to do my own laundry, or I want to cook meals twice a week. I mean, those are things that are specific and measurable and action-oriented and so forth. So we want to try to document these very specific goals so that we can ask patients about them at the next visit. But we also want to review all the risks, including side effects, including patients becoming physically dependent on an opioid if they're taking it in a scheduled or around-the-clock way, that there are drug-drug interactions, that there's a risk always of over-sedation and impairment, like driving impairment, especially when you're starting an opioid or when you're making a dose adjustment. But when patients are on a stable dose, those risks go away for the most part. But the risk of misuse and overdose. For women of childbearing age, the risk of pregnancy while on opioids and the risk of neonatal abstinence syndrome. And that some patients actually have their pain worsen over time on opioids. It's called opioid-induced hyperalgesia. So our patients should understand that there's that risk as well. And then finally, the victimization by others seeking opioids. We know there's a very high street value to these medications, about $1 a milligram for all of them. And so someone could be victimized if someone knows that that's what they're picking up at the pharmacy. So there's that risk. So it's a lot of work. There's no question about it. To do this safely, to prescribe opioids for our patients, it's a lot of work. So we need to develop and implement policies that are reflected in the patient-provider agreement. We should have management flow sheets and patient registries, pretty much similar to what we're doing now with diabetes care and hypertensive care, where we do population-based management to the best of our ability with case managers and so forth. And we need to enlist the help of other staff, like nurses and medical assistants and pharmacists and social workers and so forth, including the front desk staff. They can help, too, in terms of giving people reminders and making sure they understand what consultation follow-ups they need to go to and so forth. And we also need to have a list of referrals and support resources, including pain specialists and mental health specialists and addiction specialists, again, so that we don't have to be searching for them when we need them. And then we need to document. We really need to document the rationale for all of our decisions. And that documentation should include subjective reports from the patient, from the family, from co-care providers. Maybe they're seeing an outside psychiatrist. And standardized screens and assessments like the PEG tool. And objective information like observations that we see during our visit with the patient, drug tests, pill counts, the PMP, and so forth. And then finally, once we've taken all of these observations and information down, documented it, we then need to be careful and document our clinical and diagnostic impressions, assessments, and plans, just like we do with everything else. And one way to think about this is to think about the 6 A's. That is, at each visit or, at multiple visits, we should be asking about analgesia. How's their pain? Activities. How's their function? Adverse effects. Are they having any side effects like constipation or sedation? Documenting aberrant behaviors. They ran out early, or they didn't bring their pills in for a pill count, or their urine drug tests had an unexpected finding. And then affect, because we know that lots of patients with chronic pain have comorbid psychiatric disease like depression and anxiety, so we should be looking for that as well. And then finally, adherence is the 6th A. That is, how well are they adhering to both the medication but other things that you've recommended for them. And so patient education really needs to focus on warning about risks, warning about signs of physical dependence, warning about the risk of opioid use disorders and addiction, warn patients of the opioid effects on cognition and performance, especially when you're making changes in doses. You need to warn against use of other sedatives like alcohol or benzodiazepines. We need to reinforce the importance of safe storage and disposal when no longer taking the medication, including the dangers of sharing medications. And I think people are comfortable sharing their pain medications and giving people something for their headache if they have something in their pocketbook. And they need to understand that these medications cannot be shared. We need to counsel women on the risks associated with opioid therapy during pregnancy, namely neonatal abstinence syndrome. And we also need to warn about the added risks that we now can appreciate of high-dose opioids. What do I mean by high-dose opioids? Well, we talked about this a little bit before. That is, most folks in this field will now consider greater than 100 milligrams of morphine equivalents to be high dose. And I've listed here what 100 milligrams of morphine equals in terms of oxycodone, hydromorphone, and hydrocodone. These are really what's considered high-dose opioid therapy by different authors. Well, what do we know about high dose? Well, they're definitely associated with analgesic tolerance, that is, a decrease in the efficacy of analgesia, that there's a higher likelihood of developing that opioid-induced hyperalgesia, that in some studies, patients' function worsens when they're on high-dose opioids, and then the overdose risk that I've already shown you that precipitously increases once we get to that 100 milligram morphine equivalents. But I'm also convinced that higher doses may be indicated for some of our patients. However, being on a higher dose by itself should be considered high risk, and we need to monitor and support these patients more carefully, even if they have no other risk factors for opioid misuse. But just being on a high dose means that they're at higher risk, and they need to understand that they're on higher doses, that they're at higher risk. So when do we seek pain consultations? Well, this is from my experience. When I'm unsure of the pain diagnosis, I'm not exactly sure, is this a neuropathic pain process? Should I be looking for something else? Have I kind of misdiagnosed what's causing their pain? Or if they've got, complex pain conditions, or I'm really unsure of other treatment options beyond the medications that I feel comfortable with. And according to the Mass Medical Society guidelines that we'll talk about, we should be seeking pain consultations when patients are on longer-term opioid therapy, after 60 days, or certainly those that are receiving opioids for more than 90 days. And we'll talk more about that. And I know that pain consultations are not available to everybody. So the way I get around this is to use just my colleagues for a second opinion. Someone in primary care who I just need someone else to look at the chart or even meet with the patient and give me their opinion. Or I oftentimes will refer to rheumatologists if it's a rheumatologic problem, or orthopedists if it's a musculoskeletal problem, or neurology if I think it's a neuropathic problem. So again, we can use our colleagues that are more readily available than pain consults at this time. But there are resources, and certainly most, if not all, the academic medical centers have pain programs, but they offer different services, but certainly they're all listed here, and I'm sure there are others that are not listed, but that's a safe place to look for pain consultation. But I just want to point out here, and we'll talk more about this, that the Mass Medical Society has developed this website, Smart and Safe, that has resources for patients and for prescribers, and it's constantly being updated and is evolving. And we've talked about adding to this website references for where you can find pain consultation. Not only where you can find them, but what do they offer, and how do you contact them, how do you make referrals. And so I think from my perspective, that's something very important that is really lacking, that there really isn't one place to look for a place to go to find a pain consultation, and and hopefully this site will become that site for all of us. But there are other assessment education tools and resources that are out there. I just want to put a plug out there for our program at Boston University called Scope of Pain, which has educational videos and a faculty toolkit. You can find that Prescribe to Prevent naloxone education program on that site. And we also developed something recently for dentists around opioid use for acute dental pain. There's also a website listed here, Top Care, Transforming Opioid Prescribing in Primary Care, that has useful materials for patients, physicians, and for pharmacists. Inflection has their painedu.org, the American Academy of Pain Medicine. There's also a free mentoring program that the Substance Abuse and Mental Health Service Administration funds called the Provider Clinical Support System for Opioid Therapies, and it's free. Mass Board of Registration Medicine has information on this subject. The NIH has the Center of Excellent Pain Education materials that are available. And then there's also something called the American Chronic Pain Association, which is really a site that you can refer your patients to, where they can learn skills around self-management and self-care. And then finally, there are two sites for our patients who have developed an addiction. And certainly the Mass Department of Public Health, Bureau of Substance Abuse Services, has a helpline as well as an online reference for our patients to get triaged to addiction treatment, as well as SAMHSA, again, the Substance Abuse and Mental Health Services Administration, has a treatment locator where our patients can go to and click on Massachusetts and find treatment that's available in their locale. Now, with the remaining time, I want to move on to reviewing what are the guidelines that the Mass Medical Society has put out, and then we'll have time for questions and answers. So this is what the guidelines look like. I'm going to talk a little bit about how they were developed. They were developed by the Mass Medical Society Opioid Task Force, which included primary care physicians, pain management specialists, addiction medicine, emergency medicine, anesthesiology, and more. Consulted many resources, including other state-based guidelines and pain management guidelines from other organizations like the VA and the Federation of State Medical Boards, specialty society guidelines, as well as looking at original research and reports, including the report from the Institute of Medicine. So there were a lot of resources that were looked at before developing our own guidelines. Now, these guidelines were developed to help inform physicians of best practices for general applicability, but they are not intended to replace or supersede independent clinical judgment. So I think, we all have, our individual patients that we want to make decisions on. They were adopted by the Mass Board of Registration in Medicine, and they can be used to inform the standards of care used by the board in its response to accusations of substandard care or inappropriate prescribing. However, while deviation from these guidelines is not necessarily a per se violation of the standards of care, physicians should be able to demonstrate and ideally document the safety and appropriateness of their clinical judgment. So essentially what it means is if you deviate from the guidelines, it's totally acceptable, but you need to document why you decided to do what you did. And I think that's just good clinical care. As legislators considered measures to limit and change opioid prescribing, it's important prescribers utilize these guidelines so effective pain management is not compromised for those patients who are suffering with pain who truly need and benefit from opioids. So this is really putting everything in perspective. And, we all know that legislators are trying to come up with quick fixes to this prescription opioid misuse overdose problem, but we also know as clinicians that we need to treat our patients with pain and that some patients benefit from opioids. And so by following these guidelines, we're going to be able to keep opioids as a tool for some of our patients when they need it. Now, the guidelines also recognize that separate guidelines are needed for the treatment of acute and chronic pain, and that chronic pain guidelines apply to patients who receive opioids for more than 90 days, including transferred patients or patients that we inherit that have been on opioids for more than 90 days, and that these guidelines are not applicable to patients with cancer, patients in hospice or palliative care, and inpatients of hospitals and nursing homes. Work is ongoing with appropriate specialists and specialty societies to review opioid prescribing issues and guidelines that are unique to various specialties and practice settings, so stay tuned. So now let's talk about the active pieces of the guidelines. And so first, it's broken down into acute care, that is the initiation of opioid treatment, and there are 11 elements. Number one, physicians must be familiar with and follow the requirements of the law and regulations on use of the prescription monitoring program prior to initiating opioid treatment. So the action step here is to check the PMP prior to initiating opioid treatment. And so that's currently the law. As you all know from reading the paper, it's kind of it's evolving, and whether or not it becomes more stringent than that is checking the PMP for every prescription, we'll have to wait and see what happens. But currently, we should be checking the PMP prior to the first script. Patients should be screened or assessed for pregnancy, personal or family history of substance use disorders, mental health status, or relevant behavioral issues. So these are, again, what we need to do is assess for opioid risk. Our women of childbearing age, they need to understand that if they become pregnant, that there is a risk for neonatal abstinence syndrome. And we need to be screening for opioid misuse risk, like using the SOAP or the opioid risk tool. 3, physicians prescribing opioids should inform their patients about the cognitive and performance effects of these prescriptions and warn them about the dangers to themselves and others in operating machinery, driving, and related activities while under treatment. And the action here is, again, to educate our patients on opioid risk, especially when doses are being changed and titrated up. 4, patients with complex pain conditions, serious comorbidities, and mental illness, or a history of evidence of substance use disorder should be considered for consultation from a colleague or a specialist referral. The action step here is to seek consultation. And again, we need to be creative because we don't always have an addiction medicine specialist, but we can use our colleagues for a second opinion. But if we do have a pain or a mental health or an addiction specialist, we should also seek their guidance with patients who are complex. Again, around opioid initiation, when clinically indicated, opioid should be initiated as a short-term trial to assess the effects and safety of opioid treatment on pain intensity, function, and quality of life. And in most instances, this trial should begin with a short-acting opioid medication as opposed to, long-acting sustained release. So the action is to initiate opioids as a short-term trial with short-acting medications due to the lack of tolerance in opioid-naive patients, and we need to monitor and document benefit with assessment tools such as the PEG. 6, the starting dosage should be the minimum dosage necessary to achieve the desired level of pain control and to avoid excessive side effects. Prescribe minimum dose necessary, start low, and go slow. And so let me just briefly kind of talk about this for a minute, and that is, I think oftentimes our patients pressure us to increase their dose fast and get to a higher dose rapidly. And I don't, it's not that they're necessarily addicted or drug-seeking or misusing the opioid. I really believe oftentimes it's severe pain, severe suffering, and the patient feels that they got a little bit of benefit, but they want more benefit, so they want you to go fast. But I think if they're getting any benefit from the dosage you're prescribing, they're better off now than they were before you prescribed that low dose. And I probably wouldn't even consider changing the dose for weeks or months if they've gotten some benefit at the dose that you've got them at, because you need time to sort out if they're able to continue taking these medications safely in a way that's not going to hurt them. So I would really go slow, go very slow, as I stated here. 6, duration should be short-term with possible partial fill prescriptions or short-term low dosage sequential prescription approaches considered. So prescribe short-term with possible partial refills. So in some patients, you might want to work with the pharmacy to partially fill medications in order, again, to give people smaller supplies of medications until you sort out if they're able to take them safely. 8, physicians who work with kids should be, pediatricians should be focused here and family medicine docs. Physicians should be aware of published dosing guidelines for pediatric patients and consider body weight and age as a factor in treating pediatric patients. And this is a reference from the American Academy of Pediatrics. So again, the action here is use special dosing considerations for pediatric patients based on age and weight. 9, concurrent prescriptions should be reviewed, including paying close attention to benzodiazepines and other medications that may increase the risk of harm associated with opioid use. So obtain the patient and medication history, perform a medication reconciliation, educate patients on risks of taking opioids with other sedating medications, especially benzodiazepines. And it also includes alcohol. 10, physicians must maintain records and engage in patient assessments consistent with prescribing guidelines of the Board of Registration in Medicine, which are available at the board's website, which is listed here below. So follow guidelines on assessment, monitoring, and clear documentation. And then finally, 11, patients should be counseled to store medication securely, never share with others, and properly dispose of unused and expired prescriptions. Educate patients about this collateral risk mitigation, safe storage, and disposal. Now, in terms of those patients that you've initiated on opioids for whatever reason, and now they're on them for greater than 60 days, there are 2 other elements we need to be thinking about. We need to have regular visits scheduled for evaluation of progress when patients are on greater than 60 days of opioids. Conduct face-to-face visits for monitoring benefits and harms. 2, evaluating opioid treatment for people who are on opioids for greater than 60 days. Continuing opioid treatment should be a deliberate decision that takes into consideration the risks and benefits of ongoing opioid treatment for that patient. Patients and healthcare providers should periodically reassess the need for continued opioid treatment, tapering whenever possible as part of the comprehensive pain care plan. A second opinion or consultation from a colleague or a specialist may be useful in making that decision. So again, think about having your colleague look at the chart or see the patient and give you a second opinion. Routinely assess function and pain status. An assessment of function and pain should consistently measure the same elements to determine the degree of progress. This is where I think the PEG scale comes in, where you can kind of monitor people over time. So assess and document benefit and risk and harm, and consider a second opinion. Now we're going to move on to chronic pain, treating chronic pain, and how the guidelines define chronic pain. The MMS supports a duration of treatment of 90 days, consistent with the Institute of Medicine's definition in the 2011 report, rather than defining morphine equivalents to trigger these guidelines. This time period should trigger a face-to-face reevaluation of the treatment provided to date, its long-term effectiveness, and risks of continued opioid therapy. Physicians should consider consulting with other physicians or referrals as part of the process in developing and implementing an ongoing treatment plan. Let's look at the 16 elements. Some of them are overlapping with the acute pain elements, but this is for chronic pain that is defined as greater than 90 days or more of opioid therapy. A detailed reevaluation of the patient's history and physical should be done as soon as possible after that 90-day threshold is reached. Reassess history and physical exam. The physician should have the patient complete an objective pain assessment tool. And I think the PEG is a perfectly useful tool in this regard. That is, reassess pain and function and quality of life with the PEG. The physician should do a risk of substance abuse assessment. The physician should consider the use of appropriate baseline urine drug testing if the risk assessment or other evidence indicates there may be issues with use of other drugs or with compliance with the prescribed treatment. Conduct a substance misuse assessment and use other monitoring tools like the urine drug test. And again, the urine drug test is going to help you determine if they're taking the medication that you're prescribing, that is adherence with the medication, and not taking other drugs that you're not prescribing, illicit drugs, that put them at higher risk for misusing their opioid. The physician should tailor a diagnosis and treatment plan with functional goals at the initial 90-day threshold visit and every 60 to 90 days thereafter. Conduct regular assessments of diagnosis and your functional or SMART goals that you're setting out and documenting for each individual patient. Chronic pain is multidimensional. We talked about it acting like a chronic disease. Physicians should inform patients of the risks, benefits, and terms of continuation of opioid treatment. Alternative pain management options should be reviewed at the 90-day threshold visit and at subsequent 60 to 90-day follow-up visits. Educate patients regarding the risks, benefits, and alternative treatments, both pharmacologic and non-pharmacologic treatments, that may be available for your individual patient. Women should be counseled, again, on risk associated with opioid treatment in pregnancy. Educate patients about neonatal abstinence syndrome. Again, about pediatric patients, we need to consider dosing based on age and weight and looking and being familiar with the American Academy of Pediatrics guidelines around that. Physicians prescribing opioids should inform their patients about the cognitive and performance effects of prescriptions and warn them about the dangers, again, of operating machinery and driving. And again, this is related to when doses are being changed, when people are being started on opioids, but in this case, when people are on 90 days of treatment, if we're increasing the dose, that's when we need to warn them again about driving risk. Physicians should review the patient's current prescription monitoring program record at the 90-day threshold and then every 60 to 90 days thereafter. One goal of this review is to avoid duplication or conflicting treatments from other providers, so check the PMP regularly. And then this is a kind of long element, but it really starts focusing on the use of treatment agreements or the patient-provider agreement, that it should be established and incorporated into the medical record, and that it includes measurable goals for reduction of pain and reduction in opioid therapy concomitant with reduction or resolution of the pain and improvement in function, so that we don't necessarily commit people to 10 years of opioid therapy if the natural history of their pain is going to be to get better over time. And we need to keep re-evaluating, do they still need the opioid, do they still need the opioid? Goals should include improved function and quality of life as well as improved control of pain, and should be developed jointly by the patient and the physician to the best of our ability. It should address what circumstances would allow a patient to receive prescriptions from other providers. Say they're going to the dentist and they may or may not need an opioid for some acute dental pain, so that needs to be discussed beforehand. And it may be preferable for such a treatment agreement to be signed by the patient with an updated signature at least yearly. So use a patient-provider agreement. Physicians should discuss risks and warning signs of opioid dependence or an opioid use disorder or addiction with their patients with chronic pain. Educate patients. Physicians should discuss naloxone and its use to reverse overdoses. Physicians should offer prescribed naloxone to their patients after such discussions. And I think if you are looking for information on how to co-prescribe naloxone, how to talk to your patients about naloxone, again, I would recommend going to Prescribe to Prevent, where you'll get lots of information, including which pharmacies carry naloxone and how do you write the actual prescription for your patient. Physicians who are not pain management specialists should not initiate treatment plans which call for an excess of 100 milligrams of morphine equivalents per day without a documented consultation with a pain management specialist. Now, this is a tough one to comply with because, again, we've talked about the lack of pain management consultation for all of our patients. But I think we need to at least consider getting a second opinion from a rheumatologist or an orthopedic surgeon or from a physiatrist or somebody or even just a colleague that we work with when we have patients on high-risk doses like greater than 100 milligrams of morphine equivalents. So seek consultation. And for those patients that are already on 100 milligrams of morphine equivalents that we already have in our practice, we should talk to them about trying to get on a lower dose if possible. But if it's not possible, then again, we should look for consultation from a pain management specialist or a colleague or some of the subspecialists we've talked about already. So I think that kind of 100 milligram trigger should trigger our thoughts around, we need to get another opinion from somebody to document that this is helping the patient more than hurting the patient based on an assessment. 15, when possible, physicians should preferentially select abuse-resistant and abuse-deterrent medications when clinically indicated. So again, prescribe abuse-resistant, abuse-deterrent opioids when indicated. They are becoming more and more available, so that's all good news. And then 16, and finally, if high risk or low benefit warrants a discontinuation of opioid therapy, physicians should prescribe non-opioid alternatives for continued pain management. So that is, in our patients that we decide that opioids are either not helping them enough or are too risky, we're not abandoning the patient. We're abandoning an ineffective or harmful medication for this individual patient. The patient may abandon us, but we're not abandoning them. And by the way, we should explain to the patient that, we're going to continue managing their pain, but just not with opioids. And we explain to them exactly why the opioids are being stopped. So continue to initiate non-opioid pain management when opioid therapy is discontinued. So I think this is the end of the formal presentation. We've got a good 12 minutes or so to talk about questions.
Thank you very much, Dr. Alford, for today's insightful presentation. We have reached the question and answer segment of this web seminar. We highly encourage you to take advantage of this opportunity to ask questions directly to our speakers. As a reminder, to enter a question through the web conference system, simply type your question in the chat box area located on the lower left corner of your screen. Once you have entered a question, please click on the send button next to the box to send the question in. Your questions will not be viewable to other attendees. I will start with the questions here. The first question asked, I have inherited a patient who has been on long-term, greater than 5 years treatment with short-acting opioids for a diagnosis of fibromyalgia. I have let her know my plan is to refer her for comprehensive pain management and do not plan to continue prescribing this. What area resources are available for us, and do I start tapering anyway?
Yeah, no, that's a great question, and I think you're right in wanting to taper opioids in a patient with fibromyalgia because there really is no good. Not only is there no good evidence that opioids help patients with fibromyalgia, there's actually some kind of basic science evidence that patients with fibromyalgia are opioid resistant and their pain might actually get worse. And so I think, all in all, the patient might actually do better, and treating them with more studied and evidence-based therapies for fibromyalgia, including antidepressants, I think is the way to go. But I think trying to get this person into see a behavioral medicine specialist if you have one available, and I know that these referrals are complicated because we don't have all of these specialists available to us, but certainly there are rheumatologists that specialize in fibromyalgia. We certainly have some here at Boston Medical Center that I co-manage my patients with fibromyalgia. And I would also encourage your patient to go to the American Chronic Pain Association website because there is a lot around, there's patient education information around fibromyalgia and other treatment modalities, as well as finding pain groups that they can attend. And so I think you're right. I think you should taper the opioid because of the indication really isn't there, that is fibromyalgia. I think you should start instituting kind of antidepressant kind of therapies for adjuvant therapies for fibromyalgia. I think you should, if you feel the need, get consultation from a rheumatologist who specializes in fibromyalgia. And again, at Boston Medical Center, we have that available. I'm sure there are other places as well. And hopefully the Mass Medical Society website is going to start listing all of these resources that are available in our state that we can then refer patients to.
Thank you very much. Our next question wonders if there have been studies linking administrative use of Press-Ganey patient satisfaction scores, particularly in EDs, with opioid prescribing.
Yeah, no, there was a really nice perspective piece written, I think it was in JAMA a couple of years ago, that talked about the risk of, patient dissatisfaction or low patient satisfaction scores around this whole complex issue of opioids. And in fact, it's even one of the things that President Obama has asked HHS to look at. That is, how do patient satisfaction surveys influence physician prescribing related to opioids in particular? So I think it's a hot issue. I think there's a lot riding on patient satisfaction surveys, and I think there are going to be times when we're going to make a patient unhappy, but all in our attempt to keep them safe and try to manage their pain to the best of our ability, and that's just going to happen. So I think it's a very valid question. It's certainly an issue that people are thinking about and looking at, but I don't know any literature supporting our concerns that that's a reality. But I think we would probably all agree that it probably is. And I certainly have had patients who I've determined that their opioids are either unsafe or not helping them, where I then get a call pretty quickly from the patient advocacy representative here at Boston Medical Center asking me to clarify what's going on. And again, I think if you document everything carefully and again, try to educate the patient as to why you're making your clinical decisions, it's the best we can do currently.
Thank you. The next question asks if the directories that you spoke about would include Puerto Rico.
The directory. That I'm not sure what they mean by the directory. Are they talking about the oh, I see. Maybe it's the resources that will be on the Mass Medical site. Well, I know that we have representatives of the Mass Medical Society here, and so I think it should include Puerto Rico.
Yeah.
In terms of resources. If they're talking about the prescription monitoring program, that's another issue in terms of, if you've got a patient who you're treating who's traveling back and forth from Puerto Rico back to Boston or wherever in Massachusetts, do you have access to their prescribing records? And the answer to that is probably not yet, but there's a lot of talk about states sharing data around prescription data. That is, having kind of a centralized database so that we can at least see if our patients are getting prescriptions from neighboring states and so forth.
Thank you very much. The next question asks, do you know when we can expect final regs from Governor Baker's task force?
So, he did propose a bill around some safe opioid prescribing, legislation. And then there's a House bill, and then now there's a Senate bill. And I believe they're in conference to kind of hash out exactly what the final law is going to look like. And I know that the Mass Medical Society is spending days and days and days working on this and are ever present to kind of advocate for our patients. For our patients with chronic pain, so that they continue to have opioids available when they're indicated, but also advocating for us as very, very busy clinicians who are trying to do the best job we can, and to create a lot of hurdles that we need to go through are just going to make it impossible for us to do our job, and will make these medications less available to our patients. So thank goodness the Mass Medical Society, and listen, I'm not a paid consultant of the Mass Medical Society. I'm very delighted to have them advocating for us, because I think their priorities are our priorities and our patients' priorities.
Thank you. The next question asks, do you have any thoughts on combining medical marijuana with opiates?
Yeah, so marijuana is an interesting one because there are definitely cannabinoids within marijuana that are analgesic. It's just not the THC that people seek to get high. And so the medical marijuana story is complicated because we don't know exactly what patients are getting, and we really actually don't even know, how to get the cannabinoids that are actually going to help their pain. So, it's hard to recommend medical marijuana when we don't know exactly what they're getting. And I do know at the national level there's a lot of discussion around, doing more research on, which cannabinoids are the ones that are beneficial. And so right now I don't recommend medical marijuana, again, because I just don't know what my patient is getting at the dispensary, so it's hard to recommend anything. If the person is getting medical marijuana and I feel that they're impaired, then I consider that a huge risk factor and may not continue to prescribe opioids in the setting of that. If they're getting marijuana illicitly, then that is a huge risk factor too, because these medications that I'm prescribing go for, again, $1 a milligram on the street, and so there's a risk that they could potentially sell some of their opioids to support their illicit marijuana habit. So that's a risk factor. So I think it all depends on the individual patient as to whether or not I'll continue to prescribe opioids in a setting of either illicit, certainly not with illicit marijuana, but medical marijuana, it depends. It depends on how the patient is doing. But I don't personally, and this is just my personal opinion, I don't right now write certification letters for medical marijuana because I just don't know what my patients will be getting.
Thank you. It looks like we have time for one more question. Have any EMR programs included pain management templates?
Yeah, that's a great question. I know that Epic has had institutions that have Epic that have developed their own templates, obviously with consultation with Epic. And we've talked at Boston Medical Center, since we are newly using Epic, trying to figure out ways to do that as well without having to build it from scratch. And so I think there are EMRs, namely Epic, that I know of that certainly have tools. The question is how to access them and how to incorporate them into your own EMR. But I think you're right on in terms of having risk assessment tools that are readily available, having the ability to go right to the prescription monitoring program without having to leave your record and go to some other link. And I do know that I think Baltimore or Maryland in particular has been talking to Epic about having having their prescription monitoring program accessible right in the chart, so that it's just a tab that you go to and you get all the data that you need. So I think people are looking at that in terms of incorporating into EMRs, but also developing decision support so that if your urine shows such and such, what do you do next? And those types of tools that will be available, but hopefully in the near future.